Good evening, everyone. Thank you all for being here. My name is Inam Sakina, and I serve as the co-founder and national president of Future Doctors in Politics. And on behalf of our entire FDIP team, it's my pleasure to welcome all of you tonight. We could not be more thrilled to be sharing this virtual space with all of you for our conversation on value-based care, which we're calling More is Not Always Better. How do we incentivize quality over quantity in healthcare? Featuring our esteemed guests, Dr. Mai Pham, Dr. Robert Saunders, and Dr. Sowmya Viswanathan. We're honored to be joined by this panel of experts whose rich insights I know will leave us with much to reflect on. And we'll formally introduce them in just a moment. But before we do, we wanted to share with you a little bit about the why behind this conversation and the why behind our organization. FDIP launched just a little over a year ago as a national nonprofit with a simple but bold premise that as future doctors who are seeing the human cost of our political, our policy, our healthcare failures every single day in the stories and the symptoms of our patients, we have a unique responsibility and a unique opportunity to be on the front lines of driving the kind of structural change that serves our patients and our communities. And it's our job to equip ourselves with the mindset and the skill set that we need to be those agents of change. What began as a big idea just a year ago has now grown into a movement, thanks to many of the folks in the audience today. We now have 8 chapters in med schools across the country in our FDIP family and 10 more in the pipeline. Our chapters are our grassroots, and together we're working to fill the glaring gaps in our medical training by motivating, educating, and training med students nationwide to make policy literacy and advocacy a part of their professional responsibility. All of this combined with the national programs and the workshops like the ones we're bringing you tonight is how we hope to empower our generation of physicians with the knowledge and the skills they need to make our politics, our policies, and our healthcare systems put patients and communities first. Our North Star is really this idea of positioning ourselves to create structural change, which is a word that gets thrown around a lot. So what is structural change? Well, we think of it as first recognizing that, as Don Berwick puts it, Don Berwick being one of the great health policy thinkers of our time, he says that every system is perfectly designed to get the results it gets, which means that if we want to change the results, then we need to reimagine fundamentally aspects of our system is structured. And really, our work as an organization comes down to honing in ourselves as future doctors the ability to identify what those changes need to be and the ability to actually implement them. Value-based care, our topic for tonight, in a sense, is an example of structural change in that it's about changing the structure of how we pay for care in order to improve our outcomes. And we'll dive into better understanding what restructuring payment models actually looks like, how does it get operationalized, who does it affect, does it actually deliver on its promise of incentivizing quality over quantity, and does it ultimately make our outcomes more equitable? Aside from delving into one of the central structural changes we think that's unfolding in American healthcare right now, we also see this conversation hopefully as a reflection of our intentionally intersectional approach to understanding and impacting the defining issues facing our health systems. We as an organization believe that innovation exists at the intersections of different sectors, different skill sets, and different perspectives. Part of what has plagued our health systems for so long are the silos that prevent us from collaborating across our distinct strengths to find the solutions we know our patients desperately need. Tonight, we're so pleased that our outstanding panelists bring with them a range of lenses and an array of experiences, from the public sector to the private sector, from the clinical to the administrative to the research perspectives. And combined, they give us a glimpse of the breadth of expertise we as future doctors need to integrate into our own thinking and our training as we work to build better health systems for our patients and communities. So without further ado, let me yield the floor to Aidan Crowley, president of our FDIP at Penn chapter and a member of our National Health Policy Collaborative team, who will be introducing our guests for the evening and kicking us off. Aidan.
Perfect. Thank you so much, Anam, and thank you to all our attendees and our panelists for being here. We are so excited for tonight to really delve into this conversation and a discussion of what value-based care is and where it can take us as we move forward with a lot of the structural change and the movements that FDIP has built and is continuing to build, as Anam has described. And so because FDIP strongly believes that structural policy change requires an interdisciplinary approach, our team has intentionally selected panelists tonight from a range of career backgrounds to bring multiple disciplines together into our conversation on value-based care. So first of all, to provide a research and a policy perspective, we would like to welcome Dr. Robert Saunders. Dr. Saunders is Research Director of Payment and Delivery Reform at Duke University's Margolis Center for Health Policy. In this role, he directs a portfolio of payment and delivery reform initiatives, and he works to translate evidence into policy-relevant options. Prior to joining the Margolis Center, Dr. Saunders was Senior Advisor to the President of the National Quality Forum, where he managed a large federally funded project on quality measures for federal programs and directed special projects on payment reform and the future of healthcare quality measurement. He was previously Senior Program Officer at the Institute of Medicine and managed healthcare legislative affairs for Representative Rush D. Holt. He has a PhD in physics from Duke University and an undergraduate degree from William & Mary. Thanks for being here, Dr. Saunders. And next, from an insurance and a government perspective, Future Doctors in Politics is excited to feature Dr. Mai Pham. Dr. Pham is president of the Institute for Exceptional Care, a nonprofit dedicated to transforming healthcare for people with intellectual and developmental disabilities. Prior to this role, she was vice president at Anthem, responsible for value-based care initiatives. Dr. Pham also served as Chief Innovation Officer at the Center for Medicare and Medicaid Innovation, where she was a founding official and the architect of foundational programs on accountable care organizations and primary care. Dr. Pham has published extensively on provider payment policy and its intersection with health disparities, quality performance, provider behavior, and market trends. She serves on numerous advisory bodies, including the National Academy of Medicine, the National Advisory Council for the Agency on Healthcare Research and Quality, the Maryland Primary Care Program. Dr. Pham earned her bachelor's degree from Harvard University, her medical degree from Temple University, and her master's in public health from Johns Hopkins University, where she was a Robert Wood Johnson Clinical Scholar. Welcome, Dr. Pham. And finally, our third panelist tonight provides an administrative and a clinical perspective. Dr. Sowmya Viswanathan joined Tenet Healthcare in 2018 as the Chief Medical Officer for its Massachusetts and South Carolina, Tennessee markets. In her current role, she leads 7 hospitals based in Massachusetts and South Carolina. She's also a Harvard University instructor and a program director for executive and continuing professional education. With over 15 years of experience in leadership roles as Regional Chief Medical Officer, Chief ACO Officer, Physician-in-Chief, and Physician Quality Officer, Dr. Viswanathan has worked with large regional health systems and academic medical centers, including Dartmouth-Hitchcock, Partners Healthcare, and UMass. Dr. Viswanathan completed her internal medicine residency at Boston University, and she holds an MBA from University of Massachusetts and a master's in healthcare management from Harvard University. Welcome, Dr. Viswanathan. And so tonight, thank you everyone for, again, tuning in. We're so excited to have our panel with us and all of our attendees as well. And with that, we are going to jump right into our questions. And also, I just want to add, feel free to send in questions to the chat throughout the event, and we'll work to incorporate those as we go to bring in and really make this a conversation and a discussion with all of you. So first, we'd like to start off with a question about defining value-based care as the topic of our event tonight. Some of our attendees might come in with different levels of understanding what value-based care is, what it aims to do, and we want to make sure that as we engage in this conversation about quality over quantity, we really work with an operational definition of value-based care itself. And so this is a question we'd like to direct to all of our panelists. Maybe we'll start with Dr. Saunders and go from there. But could you please share a brief overview of what value-based care is and how it helps a health system prioritize quality over quantity? And when we say we want to incentivize quality, how do we define or measure what counts as quality in the first place?
Yeah, happy to do so. And you know, I think these are what sound like simple questions and then turn out to have an enormous amount of nuance underneath all of it. You know, at a high level, the idea of value-based payment, value-based care is that you're exchanging flexibility which is that you're able to get away from the fee schedule where you're focused on coding every single little thing in order in exchange for greater accountability. And oftentimes that's a good trade, because there's many things that you do as physicians that aren't necessarily showing up on a fee schedule. Care coordination, there's a code now for that, but in general, you spend a lot of time coordinating care, you're thinking, talking to patients, and many other activities that don't show up on the fee schedule. And so having that flexibility is helpful. And the idea is then you have accountability for quality and cost. At the extent of not having this answer go on too long, I'll say one of the struggles that we have in value-based payment right now is we have a good goal, and we've made some initial progress. There's still a lot of details where we'd like to be doing better, especially in terms of defining what is quality, in terms of setting up models that are effective and have been able to show broader change and are sustainable. But we've made a lot of progress over the last decade in order to set a groundwork.
Yeah, that's a fantastic start. And I think that point about incentivizing things that aren't necessarily directly on the fee schedule, like care coordination, is a really clear example of what value-based care can look like in practice. And Dr. Pham, is there anything based on your time at CMMI and some of the research that you've done that you want to add to our definition of value-based care?
Yeah, so I think there's a part of me that wants to apologize for my time at CMMI because, granted, one has to have a certain level of self-delusion to try to take on healthcare transformation about what's possible. But that said, I think in many ways, many of us are now looking back on the first decade of experimentation and thinking that we didn't go nearly far enough. And specifically with regards to defining what quality means and what outcomes really matter. I think that we began with easy first steps, and it was perfectly logical to focus on measures of quality that were based on clinical guidelines, that were familiar to providers, that tied directly to specific clinical services like aspirin after a heart attack. But in reality, those are not necessarily the measures of quality that have meaning for patients and for communities. And so I really think where value-based care needs to go is to refocus itself on those outcomes that actually matter, which requires a different kind of design process. It requires consulting with patients and communities, and it requires thinking about all of the contributing factors to health and what a person wants to use health for, not just health care. So if that's the ability to go to your granddaughter's wedding, you can work backwards from that to, then why is it important to make sure that, your hips are okay and your back is okay and your blood pressure is under control, because we want to get you to your granddaughter's wedding. And then it's not about a particular hypertensive drug regimen. It's about the outcome and whether that person managed to reach their goals. There are technical ways to approach these things. I know it sounds very high level and idealistic, but there are ways of setting those kinds of goals and standards. And then having that flexibility that Rob talked about can feel really empowering. Because then you're in the ideal, you're getting to do what we all went into clinical training to do, which was to solve our patients' problems. We didn't go, I don't think we actually signed up, in any of our medical school essays to say, I really want to grow up and follow clinical guidelines. Right. That was not the inspiration, and that's not the oath that we took.
Yeah, and I appreciate your thoughts too on thinking about not only where value-based care has been, but where it can go and what directions it can take in the future too, because that's definitely something we wanted to bring in tonight is, while it's an amazing concept and a great ideal to prioritize quality and outcomes, who's to decide which outcome is better and which ones we incentivize and how we do that. And it's really in engaging with conversations with community members and stakeholders and the patients themselves that we can decide what counts as valuable and how we can push care in a direction that really does prioritize our patients. And Dr. Viswanathan, from your perspective, running hospitals and things like that, how do you define value for your clinicians?
Sure. Thank you very much. Good evening to everyone, and thanks so much for this opportunity. As a practicing clinician and as the chief medical officer now for hospitals, but I have also run ACO for a large health system. I've also been in the ambulatory integrated care side for another large academic medical center. I feel like I want to bring that practical aspect to this discussion. Just falling back on both Dr. Saunders as well as Dr. Pham's comments, it's really critical that the journey of value-based care has drawn us to consider what is the appropriate care that's given to patients and what is the right care at the right time in the right setting. I mean, that's how I would call value-based care. Basically, how much care are we providing? Are we providing in the right setting for the patient at that time? So when you really look back, I think, many things of this jigsaw puzzle had to be fitted together. If we didn't have payment systems that would incentivize for care to be delivered in an outpatient setting, then we wouldn't have that momentum of the patient being cared for in the ambulatory setting when they could have been cared for in the ambulatory setting. If we didn't have the infrastructure support that is required for patients to be cared in the ambulatory setting, then that is not going to happen. So right now, all these pieces are coming together because payment reforms are actually indicating if we will incentivize you for caring for this patient in an outside the hospital setting, if you can safely do it. So everything is taking together the context that as long as quality care is provided and patient safety is not compromised, and you can care for that patient in an ambulatory setting or in an outpatient setting, let's do it. Patients heal beautifully in their homes. Patient heals much better when they're outside the hospital. There is risk of being inside a hospital because you do expose yourself to all kinds of infections. There is increased risk of falls when patients are in the hospital. So we want patients to be cared for in the appropriate setting. And that is what value-based care is driving us to do. I think it took us a long time to engage with physicians because habits change slowly. And physicians were incentivized in the past to say, we will pay you more to see more number of patients per day. We will pay you more to do more surgeries per day. Whether it was required or it was borderline, there was very little incentive to say, if you don't bring the patient to the hospital, I will pay you more. And now we have reached a point where people are understanding that patients heal better when they are not in a hospital setting. Let's see how much we can do safely in an outside the hospital setting. And that's primarily what I think is driving. And fortunately, all the forces around us are coming together and putting the right policies in place, whether it's going to be with health plans or whether it's the government-run plans or whether it is even physician groups. They are accepting of ACOs and they are saying, okay, I want to be part of an ACO because I'm willing to take more risk and be in risk share contracts as long as I can do the right thing for the patients in my community. Thanks.
Thank you for that overview, all three of you. I think it gave us the glimpse of the different lenses into value-based care that we really wanted to feature in this conversation. Dr. Viswanathan, you just touched on the provider, the physician perspective. I want to switch gears and touch on the insurance company perspective. And Dr. Pham, you served as Vice President of Anthem and specialized in their value-based care initiatives, Anthem being one of the largest providers of health insurance in the country. Can you take us back to when that initial shift from fee-for-service to VBC was transpiring and what that looked like on the ground for an insurance company? What did the changing incentives ultimately mean for insurance companies, and how did the companies think about that change, and where do we stand now in that journey from fee-for-service to VBC overall from the insurance company perspective?
Sure. So I want to clarify something, which is that it's a myth that we have gotten rid of fee-for-service. Fee-for-service is alive and kicking and well, a little bit too healthily, I think. And the other reality is that the vast majority, if not all, value-based payment arrangements are built on a chassis of fee-for-service, meaning that they, the way that budgets are set in value-based payment arrangements, and how providers are graded in terms of their performance in value-based payment arrangements is all based of actual fee-for-service billings. And so we have not evolved in that sense as far away from fee-for-service as one might want to see. That's important to remember. You know, I think what it looked like when it was more pure fee-for-service was that the relationship between providers and health insurers was really about price. And you know, it might be about some special quality projects, or it may be about fraud and abuse, but it was largely about price. It was largely about, you know, per unit of my service time, what will you pay me? And how much market leverage do I have as the health plan or as the provider to push that number as extremely as I can. In the era of value-based payment arrangement, I would not say that that has gone away. In fact, I'd encourage you to remember that it's a very complex system. And in this system, there are all kinds of providers and there are all kinds of insurers. I, in fact, walk around in my head with a certain archetype of each. So for providers, for example, there are about 4 or 5 archetypes, depending on how you count. They're the true believers, right, who can't live any other way except under a value-based payment arrangement. They have been known to even lose money in an effort to get good at it, right? And so they have street cred because they've made that investment and it's a long-term commitment. Then there are the adventuresome ones, right, who are very empirical. I would put my older brother, pulmonologist in private practice, in that category. And I would describe these providers as being willing to try anything at least once, but then they're going to see if it makes sense financially. And as soon as it doesn't, they drop it. So they're not true believers, they're very empirical. Then you've got the market followers, the ones who kind of sit on the fence and wait to see which way the wind is blowing, and then they'll follow more, you know, lagging a little bit behind and maybe more tentatively, not making the deep investments. And then you've got the scaredy cats, right? The ones who are not just waiting on the fence, but they're waiting for someone to push them or someone to really entice them in. They need an extra layer of reassurance. They're not as confident. And then you've got the folks who have no business reason to move into value-based care, who they tend to be providers and provider systems who are doing very well in fee-for-service and really don't have much incentive to become obsolete. And very few insurers, including Medicare, have forced them into value-based payment. They just have too much market leverage to do that. So it's quite the patchwork across the industry. And I would say, while the trend has certainly been in the direction of more value-based payment, I would not say that we have reached that tipping point where it has become the default mode of operation for the care delivery system or for insurers. Insurers would love to get into that phase of evolution, but you know, for a variety of reasons, market dynamics and competitive pressures and you know, operational costs and hurdles that frankly insurers get in their own way of doing some of these things. It's a complicated picture. I think you'll learn about me that I'm a hopeful cynic, I think. So I think the more cynical one is, the more radical the solutions one tends to recommend. And what I see when I look at the landscape is, yes, we generated some momentum, but we actually didn't get into the game the providers who most needed to be in the game.
Thank you so much for that answer. That was, I think, extremely illuminating to our attendees here tonight to hear about the different archetypes and what it looks like to have something be an idea or an ideal of talking about quality versus actually changing and shifting a system that really is still structured and set up for fee-for-service. And that while it might be nice to talk about or think about prioritizing quality, you can see all the hoops and hurdles that end up when you get on the ground level in terms of finances and incentives and all sorts of habit change, like Dr. Viswanathan brought up, that can take something from being an idea to reality much longer or more difficult or complex than you might think it would be from the surface. And on that note, we'd like to ask Dr. Saunders, from a research perspective and some of the work that you've done at the Institute of Medicine and the National Quality Forum in managing these projects on quality measures of payment reform and the future of quality measurement itself. How do we go about translating this research evidence and testing or piloting value-based care and the outcomes that we do see to actually policy relevant options?
Yeah, and there's probably a few thoughts here. I think one thing to note, especially as we're talking about value-based care, is that this conversation looks a little bit different in 2022 and the second year of a public health emergency than it did in 2019, early 2020. And so I think that's one thing to know. I think one thing the pandemic did is it did note how fragile fee for service was, especially for the primary care folks. In early 2020, you saw a number of primary care practices who were under more traditional, fee for service billing arrangements really struggle because their in-person revenues just dropped. The telehealth reimbursement really hadn't kicked in yet, and you saw a lot of furloughs, closing doors, layoffs. You even saw that, frankly, on the hospital side. And so I think we're in a little bit of a different place than we were, before the public health emergency, and that we've had that experience. Now in 2022, I'm not as sure how much of those lessons, it's been a few years, some things have come back to normal in healthcare, some things probably may never come back to normal. But I think there is a little bit of a differing appetite and willingness to talk about value-based payment, now after having gone through, what a challenging experience than, before the public health emergency. So that's one consideration here. I think on the translation side, and I'd be interested in Mai's thoughts as well, and always enjoy being on panels with her, is that, this is really complex stuff and it is difficult to explain, and it is in some ways easy to have these high level conversations. But when you get down to details and try to have this conversation with, individual docs on the ground and individual patients, it's a lot more challenging. Patients kind of look at you when you talk about value-based care, and there's some public, media polling and the like that have looked at this and say, people think, oh, are you talking about Walmart for my care? What is this about, taking things away from me that I should have? For individual docs, I think it can also be a challenging conversation. And we haven't necessarily figured out that messaging. And that sort of hits to the third point, which is if we can't explain it to real people on the ground, we run into a real buzzsaw on the policy side where, to be able to see real progress happen, especially among very busy policymakers, whether the executive branch side or the legislative branch side, you need to boil this down to essentials. And I think we're still figuring out how to talk about value-based care in a lot of ways. So those are my 3 points, I think, to make on this translation point, that, we're a little bit different place now that we're in COVID. We're still figuring out how to actually talk about value-based care. And that's been a bit of a challenge as we're working on the policymaker side.
So if I could just follow on that for a little bit, I appreciate Rob's point, because when I was at Anthem, the evolution that I tried to make beyond where we had been able to get to at CMS was to think to start edging toward those outcomes that matter to people. And what I challenged my team to do was think of requirements for providers or services or performance metrics in the overlap of that Venn diagram between things that would reduce total cost of care and things that would improve patient experience. And so not cappuccinos, right, in the waiting room, but e-consults, right, or telehealth. Now, understand this was 2019. We designed it in 2018 and went live. And so it went live before COVID. And, the organizations that we negotiated with, some of them kind of they really wanted to do it, but these new things, the e-consults, really seemed like a stretch for them, and they kind of fought it tooth and nail. 8 months later, they seem really smart to their peers. Why? Because it just has its own inherent logic. If you can prevent a patient from having to take a day off of work, sit in traffic, then a parking lot, then a waiting room for a 10-minute conversation with a GI doc that could have been done asynchronously. Like, why would you not do that, right? But it's not the mindset that I think we have traditionally come from in the care delivery system. We haven't thought about, let's start with what the end user needs, and then let's work backwards from that. So it's a paler version of my dream of starting with life and health goals and working backwards from that. But that was kind of the transition framing that we tried to get to in that particular program.
Staying with this theme of thinking about outcomes in terms of the patient experience and what actually matters to our patients, Dr. Saunders mentioned that we're obviously living through a once-in-a-generation pandemic where the experience has been incredibly inequitable. We know that as a country, our outcomes have always been inequitable, but inequity in a sense has very much deepened over the course of this pandemic. What has been the experience of VBC in impacting equity specifically? And we'd love all of your perspectives on this, but perhaps we can start with Dr. Viswanathan for this one. I think you're muted, Dr. Viswanathan.
Okay, I'm sorry, I couldn't get unmuted for a minute. My apologies on that. So the last part of your question actually got cut off as well. So something happened, some glitch happened. So I'm sorry,
No worries, no worries. The question was really on equity, thinking about value-based care and its impact on just the general landscape of health outcomes in general being inequitable in this country. How has value-based care affected that when we think about the patient side of this?
So when we look at healthcare disparities and healthcare inequities that exist, one of the most important things was just access, right? Access to care, and how we are distributing the totality of how healthcare access is distributed amongst a community or a population. And that's basically the premise of population health management. So for example, when I was at Dartmouth-Hitchcock, we lodged into actually, it was with Anthem's CareMore program. And Dr. Pham may be familiar with the CareMore system, but we actually started engaging with CareMore to figure out, how can we build a system off of the CareMore model, what we called as the step down from the hospital side, where everybody has equitable care that is provided for them in one single setting. And the whole process of how we are looking at the payment models is taking a secondary role. I have to say, for this to happen, it was an extremely slow but very, very well-grounded process. It took a long time for us to actually engage. And the three things that needed to happen, and I'm speaking more practically from what we actually tried to do, and it still is a prolonged process, but I'm sure Dr. Pham and Dr. Saunders will be able to provide more discussion points on that. But the three things that needed to come together for us to actually provide that kind of a healthcare platform was, I needed leadership engagement. I needed physician engagement. And then I needed some sort of a technology engagement. So this integration had to work at all the three levels for us to really move forward on this movement. Because if I didn't have leadership engagement and leadership integration that's going to allow me to create the infrastructure that I needed to provide that kind of care, I would not be able to move forward and set up all kinds of models of care delivery for me to talk to the physicians. So the next came the physician engagement. If the physicians were not leveraging with us and we were not able to get their buy-in, I would not be able to move forward with anything. And the physicians were unable to do a lot of things until we had technology integration. So I feel like there was a lot of momentum that I was able to build. And this happened mostly in 2018, pre-COVID, and we call it pre-COVID and post-COVID these days. But pre-COVID, when we were already instituting how do we disseminate and how do we integrate systems with technology? And we started looking at e-consults, and Dr. Pham actually pointed out to that. So e-consults became very popular, and tele-visits. We had a tele-ICU, we had a tele-pharmacy, we had tele-everything at Dartmouth because we were able to disseminate and embrace the technology platform on that. I know it's not directly responding to your question, but I think, it was important for me to bring the criticality of how that momentum is built. And it takes like a true 3 different villages for us, whether it was the physician, whether it was leadership, or whether it's the technology gurus who are helping us in that process.
And I can jump in next. I think there's probably 3 ways that I would think about how value-based payment intersects with equity. One way to think about it would be, and it varies on the different type of value-based payment. There's a lot of different flavors here. But one way to think about it would be looking at value-based payment arrangements that can provide greater financial flexibility, which then can be used for services that are traditionally associated with social drivers of health. And we saw a fair bit of this happen during the public health emergency, where a number of, say, ACOs were using some of their financial flexibility, their shared savings that they maybe had to address many of the social drivers that had become much exacerbated during the public health emergency, and help to address those needs. And so I think that's one bucket where the financial flexibility from value-based payment can be useful in addressing equity. But as we know, social drivers of health does not necessarily equal all of equity. There's a variety of other issues as well. There's also a variety of technical aspects to value-based care that can affect equity. I think one thing that is hopeful in value-based care is the focus on populations. Pre-value-based care, especially if you're in a fee-for-service arrangement, you're really focused on the person that comes in, and that's hopeful, and you're solving the problem for the person that comes in, but you're not taking that step back and saying, what about the population of patients? And so, in early value-based care, we may have been focused more on, let's make sure all diabetic patients have come in, and we've had a recent A1C, and we're checking, or we've made sure everybody has their all my hypertensive patients have, a statin. But now, we can also think about value-based care's focus on populations to look at, inequities and to look at disparities across the, your patient population. Now, that requires data, and that's not always there. In fact, most of the time, especially in race and ethnicity, the data is quite poor, and sometimes almost non-existent. Except for centers that have really, really focused on this in the past. And then I think the third part of value-based care and equity that's worth flagging is, especially under this administration, the CMS has really focused and made a major push on including equity in models. There's a lot of technical pieces that'll need to be figured out for how do you use those value-based payment models to help incentivize equity further than what we've done so far. And I think that's something to watch over the coming years as those models get rolled out by the CMS Innovation Center. But those would be the 3 ways that we've seen equity addressed so far, and then where we might see equity addressed in the coming years.
Yeah, and I guess I will supplement. I agree with all of those comments. And I would supplement by pointing out a few things. One, that to date, we have only seen a very small number of examples where a value-based payment program actually reduced disparities of any kind, right? So I would point to the Alternative Quality Contract in Massachusetts. I would point to the Maryland Primary Care Program as 2 examples of that, but they're 2 in a sea of many. And that's in part because no one was looking at it, right? No one had set reducing disparities as a goal. Now that we've set or begun to think about setting that as a goal, we turn to the how, and that's what Rob was referring to. And when we turn to the how, I think it's important to understand that there are different sources of inequities, right? So let's just take racial ethnic ones because they're paradigmatic. It's different to talk about, say, disparities for people with disabilities. But if we talk about racial ethnic disparities, one, I acknowledge Rob's point that the data are not perfect. I also want us to not use that as an excuse. We're not going to wait to act until we have better data or perfect data. We're done with that. It's been several decades since David Satcher's Surgeon General wrote about health disparities, I think he's waited long enough for us to act. But I would also say that regarding those various sources of disparities, sometimes disparities occur because of within provider variation. So the same provider is treating different patients differently, either consciously or not. But then other degrees of disparity creep in when you have between provider variation. In Medicare specifically, and I would venture to guess it looks pretty similar in other insurance lines, it's the 80-20 rule, right? So healthcare delivery is as segregated as is housing, as is education in this country. So roughly 20% of PCPs are responsible, deliver primary care services to over 80% of Black Medicare beneficiaries. So it's highly skewed. And those PCPs that serve more Black beneficiaries also happen to have worse payer mix. They happen to have less private insurance contracts and are more reliant on Medicaid and Medicare. And what happens as a consequence is that we have to remember you have to pay to play in value-based care, right? It takes infrastructure. It takes upfront investment to hire the nurse care managers, to create your analytic platform, right? To do the outreach, to measure, to change your EMR. Every time you change an EMR, it's many tens of thousands of dollars. So that's very hard to do if you are cash strapped with poor payer mix. And it's a double whammy because your patient population probably has higher levels of life and social stressors in the way. So you're doubly disadvantaged. And I think what we have learned is that through models like the ACO investment model, it can make a huge difference when payers recognize that variation across providers and invest smartly in infrastructure support for those providers who don't have the means. Because in the absence of that, which is what we've seen, say, in the Medicare Shared Savings ACO program, you see less participation by organizations that serve disadvantaged populations. And that is definitely not value-based payments solving disparities. So there are multiple levels here. And then once you've decided you're going to make the infrastructure investments, you're going to give people some kind of a level playing field. The other way to address this kind of chronic structural inequity in access to resources is to think about pricing things differently. Within a value-based payment arrangement, there are all kinds of technical decisions that one makes about how you structure that arrangement, right? What your financial baseline is, your benchmark, how you risk adjust, any discounts, all these terms you don't need to understand right now. But each of those decisions is an opportunity to make a deliberate choice to favor some kinds of care settings and some kinds of populations that may need it more than others. And we can argue policy-wise whether that needs to be a zero-sum game. But the point is, we are trying to address inequities with one hand tied behind our back if we just kind of assume passively that the current prices should stay what the current prices are. We literally value people, some people less than others right now in the way that we pay in terms of prices. If we're serious about addressing disparities, we have to tackle that problem too.
Yeah, thank you so much for that. And building directly off of that, when we started this panel tonight, you mentioned that you really think it's time to see value-based care do more and to push the envelope further on that realm. Now talking about not wanting to wait for the perfect data to come in, but to start moving and really taking action in pushing these changes forward that you talked about. Some people wonder if the bar or the standard of evidence for implementing value-based care and piloting these programs is too high. So for example, requiring it to be cost saving before it would implement rather than being maybe cost neutral, but adding some quality metric. And so given the standards, at least that Medicare has had for implementing value-based care models in the past, what do you think should have to happen with the criteria to change for these value-based care or bundled payment demonstration projects to actually be scaled to health systems levels?
Well, if you're asking me what the likelihood is of an act of Congress that would change the Mai statute, I think it's fairly low. But what I would say is this: I think that there are ways to implement value-based payment, I'll describe in theory what I think needs to happen. I think one needs to acknowledge that a high-value system, to get to a high-value system, does not mean that you should try to squeeze savings out of every single component in the system. There are components of a high-functioning system that we have underinvested in for many years, like primary care, like rural healthcare, like behavioral health, right? That we need to invest more in. And you should not have the expectation of generating savings from that silo. And you should be prepared to wait for a much longer time frame than we are typically used to doing. 3 to 5 years is nothing. It's the blink of an eye, in the consciousness of American healthcare. I think my on-the-ground colleague will attest that 3 to 5 years, you might get some culture change within your organization, right? So it's those things. You have to have a much longer time frame. You have to understand that some places are going to require more investment. And frankly, you have to be willing to do what I think is the most politically challenging thing we need to do, which is to make the counterfactual to value-based care much less attractive. As we said at the top of the hour, fee-for-service is alive, well, and kicking, and it remains far too attractive. You have to make fee-for-service increasingly unattractive relative to value-based care in order for that, magical pivot point to really come to pass.
I have an audience question that we'd love to bring in here, and it's about Medicare's prospective payment system, which was instituted about 40 years ago now. And the question asks, why do we think value-based care is going to be different? It's one of those things that sounds great, but real value is decreased mortality and quality adjusted life years. These are things that take years to measure, and you can't go back 10 years later and adjust a provider's reimbursement. How would you respond to that? And I'll maybe Dr. Viswanathan, you can start us off here.
I think the important thing to remember is that there is a true evolution going on, and evolutions are always slow. They are not going to be fast-paced, and it's not going to happen overnight. So the discussions on value-based care had been happening for a long time, and we had done experiments across the country, whether it was a Medicare Advantage program, and that's probably the only program that even showed any momentum in value-based care for the longest period of time, because they felt like, okay, we were able to look at risk-shared contracts, and we are able to make some movement. And then came the ACOs. They had been trudging along very slowly. I have to say that probably the reason I personally, at the ground level, again, I personally feel like we have really moved forward fairly quickly over the past few years is the burst and evolution in technology-based healthcare. So whether it is televisits, whether it is teleconsults, whether it's e-consults, whether it is embracing electronic health records, which most physicians have still not embraced, but it almost became like mandatory for people to really embrace electronic health record, because that was true integration that was happening. And once the infrastructure was formed where an EMR was able to connect, and the interoperability between the ambulatory setting to a hospital setting to a surgery center, for example, was happening, whether it was an urgent care center referring a patient in, that interoperability needed to occur for a few reasons. The physicians needed to feel comfortable that they are actually able to take good care of patients in whatever settings they are. EMR and the interoperability allowed us to actually mine data to a certain extent. There is still a ton of pushback from physicians, because anytime you bring data to them, they are still going to say this data is not correct. It's all, it doesn't reflect me. I'm doing the right thing, and this is not me. So we keep getting the pushback, but data mining and actually putting forward data in front of physicians help to move this momentum together. And I think the third one is just the patients themselves. The patient engagement has been much higher they have become more tech savvy. They are using a lot more of the patient portals. I have so many of the next generation patients in my panel, a ton of patients who are actually using patient engagement platforms. So I'll give you an example. When I was, again, going back to Dartmouth, we actually had done a pilot with Microsoft where we had given those Fitbit type, wristbands to patients. So they were able to track. At that time, it was just the blood pressure and pulse and their EKG reading, no matter where they are in the world. It was a pilot that actually blossomed beautifully. So there was one patient who went all the way to the summit of Machu Picchu, and we were able to record the blood pressure and pulse rate. I mean, that is how much interconnectivity has occurred. And we were able to log the trend of the blood pressure as he was climbing up. And that kind of patient portal has allowed us to engage with patients better. So the patient engagement is moving us forward. The physicians are now able to conceptualize that, okay, this is how healthcare is going to be. There is an infrastructure, again, it's still weak. I think there's a lot more infrastructure that needs to be put in place in terms of care coordination efforts, but at least an EMR integration is starting to occur. I think so. Would I say value-based care has, we are talking a different language now because we are getting closer to implementing value-based care everywhere. I feel much more optimistic, let me put it that way. And perhaps the COVID and all the televisits that we were able to achieve through COVID has made me a little more optimistic that value-based care is probably something that could be achieved as long as we continue to turn this Ferris wheel. The inertia is there. Initially, we have to put in a ton of energy, but once the movement starts to occur, I think the speed will pick up. Thank you.
Yeah, and thank you for your thoughts too with those examples of how some of value-based care has been implemented and what it's looked like to change things for providers and for patients, and to really hear about how providers react to the implementation of value-based care and how, even though it might be slow, we can get the wheel moving and turning. And we have a couple of audience questions that we'd like to bring in here on this point. Maybe we'll direct them to you, Dr. Pham. First of all, one is asking about value-based care as playing a role in changing compensation for providers. So some of what you talked about with paying primary care physicians more and shifting those incentives to really increase compensation for things that are quality outcomes, and maybe even incentivizing more medical students to go into specialties like primary care so that we can build out that workforce. And a similar question from another audience member asked about not only telehealth and telemedicine as an example of value-based care, but other current projects that are ongoing to implement value-based care.
Sure. So the compensation question is complicated because I think value-based care has the potential to really change provider compensation. But there are two components of compensation, well, three components of compensation, right? One is what the price is that you're getting, right? Whether that's for a unit of time or a unit of service. Then there's the cash flow mechanism. In what form is that payment coming at you? Is it coming in fee for service or is it coming as a monthly payment, right? The price is somewhat disconnected from that, right? And then the third component is there some kind of accountability rubric that wraps around the price and the cash flow mechanism such that you have some kind of performance risk, right? If you perform better on whatever rubric, you get more. If you perform less well, you get less. So those are like the basic elements of compensation. And I would say that value-based payment offers certainly changes in cash flow, that flexibility that Rob talked about. I don't think value-based payment has really changed the relative prices for different services. And that's why you have not seen a dramatic change in the quote unquote value of primary care, because it's still based on that, finicky fee schedule, and those prices and the fee schedule are still as distorted as they have ever been. So that, neurosurgery gets, a given neurosurgical procedure will net that provider a much higher profit margin than a given consultation about somebody's multiple chronic conditions, right? So the potential is there, but the reality is, and I believe Rob did some of this survey work, the vast majority of organizations in value-based payment arrangements are still compensating their clinicians on mostly a fee-for-service basis with a little bit of a performance rubric. So we're waiting for these incentives to get transmitted down as deeply as possible. It's hard, I think, for provider organizations to fight, what is mainstream in a labor market, and again, those relative prices. I think that if the owner really of the master price sheet in the country is Medicare, and if Medicare had the political cover to rationalize those relative prices in the fee schedules, I think you would see some dramatic changes in the impact of value-based payment arrangements. But that is a whole other conversation, and that probably should be done with alcohol.
Time has really flown by. There are so many threads in everything that all of you have shared that we would love to have been able to pursue over the course of a much longer conversation. But as we close out, we'd love to hear from each of you just one takeaway maybe for the medical students that are assembled here this evening that they should remember as they think about their futures in medicine and how they should prepare for this shift to value-based care that they'll be experiencing as they graduate into the workforce. Dr. Saunders, we could start with you.
Sure. And I think especially while you're in medical school, the traditional curricula focuses so much on the basic sciences, which is important and definitely needed. But I think as Dr. Viswanathan said, there's a lot of competencies that you need in value-based care that go beyond the basic science, and understanding how to look at populations, understanding how to think about workflows that are worthwhile thinking through. And then since this is a health policy and thinking about future doctors and politics, and having spent time on the Hill, I do want to also say that there are opportunities to think about how to explain all of this to audiences that are on the more public-facing lay audience side, and that can be really helpful both for professionally and also for your own clinical practice.
I can go next. I guess I would say to you all that you are our great hope. I do think that there are some really meaningful generational differences, and I see younger clinicians being so much more comfortable thinking about diversity and intersectionalities, so much more comfortable with the concept of team care, because physicians can't do it all and shouldn't do it all. And being willing to share power in that way. And I think that, being willing to, in some ways, paradoxically, looking for a work-life balance in your own lives tends to force the people who want to hire you be more humane. And that translates into your capacity to be more humane with your patients and to really think about outcomes that matter. And not least, this spirit that you have in being a part of a group like this to become politically active and to stay that way and remember how much influence you will carry as a physician. That's not to be wasted. And so I just really applaud you, and I'm begging you to hurry up and get out there.
I couldn't agree more with Dr. Saunders and Dr. Pham. I have to say, first of all, it has been a fantastic opportunity to be in front of you. And as future clinicians, a couple of takeaways that I don't even know if I should call it takeaway. The movement has already begun. And as Dr. Pham just put it so eloquently, it is gone are those days where the physician and patient had that one-on-one interaction. Now it's group sessions, it's a teamwork, it's an entire team that takes care of the patient. And the fact that you are already engaging in the conversation on case management, care coordinator, APPs or nurse practitioners, physician assistants, there's a whole host of clinical pharmacists, this whole host of team that is there to support the work that you have to do, you can get a lot more work done in a short period of time managing a huge population. And that's where population management comes from. It's basically an entire team that takes care of a community and serves them well. The only other takeaway is I think we're already there, embracing technology. That's here to stay. It's not going away. And how you can leverage technology to actually deliver better care, whether it is through the televisits, but also engaging the patients. The more and more patients engage through whether it's electronic health record, direct communication with you, wherever you are, basically you are the caregiver, and the more you can do with technology, which is not going away, we want to use it and leverage it to our success. So best of luck to everyone.
Thank you all so much for everything you've shared this evening. I know we've all found this to be such a phenomenal event. We have learned so much from the 3 different perspectives that you brought and really left this on such an empowering and hopeful note. So with that, we are now concluding our event for this evening. Thank you again to our panelists and our attendees for joining us and engaging in such a wonderful conversation. And if tonight has inspired you and you want to get involved in building this movement for change with us, you can follow us at Future Doctors in Politics and reach out at info@futureindoctorsinpolitics.org. And keep an eye out for our next event, and we'll share more about that in the weeks ahead on social media. Thank you again, everyone, for being here, and have a wonderful evening.